This
By the way,
conference
for
will
those,
now be recorded.
this is Rick Davis. This is the 4th of March call group, I should say, for high-risk recurrent and advanced cancer, the AnCan group. And we've been away for a week. So we've got a fair number of guys and a lot to cover. And for those of you who really enjoy Ben moderating, don't miss next week, because he's going to be standing in for Peter, and I guess I'll have to be the chief muter and recorder and unrecorder and all of that. So,
Rick, it's the 4th of April, not the 4th of March.
Yes, it's the 4th of April.
4th of April, right. Today, oh, did I say the 4th of March? Sorry, 4th of April. Right. Okay. All right. Mr. Willis, I should say, where have you gone? I've lost you on there. There you are, Mr. Siegfried, I should say. What we usually do with new men is we ask you a few questions, and then we give you some time to ask us questions, and we comment on your case, and from there we hope you'll come back. So I'm going to ask you a few questions, and we'll run down this, answer them as best as you can, and so you come from a great source, because we like Mr. Fabish, Captain Fabish, very much, and I think we've probably helped him quite a bit. How old are you, Willis?
I am 77.
Okay. And where do you live?
I live in Boulder, Colorado.
Oh, we got a few compatriots of yours here. I see at least two. I see one now, Don Price, and oh, there's another guy who'll help you with your moderation, Joe Gallo, Don Price. We forgot about that, and a former resident of Boulder, and Peter Kafka. What year were you first diagnosed?
2001.
Whoa. Okay. And cast your memory back and tell me, if you can, tell us, if you can, what was your Gleason score and your PSA level at diagnosis?
I think my Gleason score was 6. I'm trying to remember, so this could be wrong. And my PSA was somewhere below 20.
Okay. Do you think it was close to 20, or do you think it was like close to 4 or 5? Which end of that scale?
I think it was closer to the lower end.
Okay. Okay. Now, at that time, where did you go for treatment?
I went to the University of Pittsburgh Medical Center, and I was treated by a surgeon there by the name of Joel Nelson.
Okay. And how exactly did he treat you?
I had a prostatectomy in March 2001.
Okay. And I'm suspecting because you didn't have a 4 in your number, that you probably didn't have any scans. Did they do any bone scans at the time, or any CT scans to see if the disease was out?
I don't recall that, but I do recall that the post-surgical pathology was clean, and
Okay.
my PSA post-surgery was undetectable, and it was that way for 5 years.
Very helpful. And low and undetectable for 5 years. Now, that takes us up to 2006. So why don't you bring us up to date from 2006 onwards?
Well, in 2006, the PSA became detectable, and we elected to not do anything right then because it was just barely detectable. And my surgeon said that the rise of my PSA, once it became detectable, was the slowest that he had seen in his practice. And so we waited until, well, he recommended at that time that I have X-ray to see if we could cure the cancer that had come back. And so I went through external radiation, but that was unsuccessful. So after that, we continued to watch the PSA, and I'm hazy on the exact time, but I'm going to say around 2015 or 16, the PSA had gotten to a relatively high level, and I had some evidence of metastatic disease in some lymph nodes. At that time, at Dr. Nelson's recommendation, I began hormone therapy with Lupron, and I was extremely successful because I think my PSA went from 250 to 0.1 after the first Lupron treatment.
Let's hold on there a minute. Let's hold on there a minute, because I was going to ask you, when you started in 2015, what was your PSA? And now I hear you say it was 250?
Before the first treatment, it was 250.
Okay, how on earth did it get so high under the auspices of Dr. Nelson?
Well, I'm a little hazy on this, but I think because I had no symptoms, and it wasn't until then that I had the first evidence of metastatic disease in a lymph node. I think that was the reason that we waited that long. I think we discussed it, but we agreed to hold off until then.
Okay, well, I won't comment, but I got a feeling some other people might a little bit down the line.
Okay.
You went on Lupron and Lupron alone, or anything else with the Lupron?
Lupron alone.
Okay. And how long did that keep you at undetectable?
Well, you're asking me for details that I'm gonna have to do research, but basically the first, I guess you get 2 injections under that treatment over a several week period. And the PSA went from 250 to, I think it was 0.1 or 0.2. And it stayed that way for some time. And I can't give you the time intervals, but we decided to go with intermittent Lupron treatment. And that has worked very well for me. Presently, we wait till at the last episode, when the PSA got to 10, I had another Lupron treatment and it went back to 0.1 or 0.2. And I'm usually having about 6 months in between treatments where the PSA stays low enough that the oncologist is good with me not having a treatment until it gets to around 10.
Now, who is treating you now?
I'm presently being treated by a Dr. Sitarik at the Rocky Mountain Cancer Center here in Boulder.
Okay, and is he a general oncologist, or does he specialize in prostate cancer?
He is not a specialist in prostate cancer, and I've been looking to see if there's someone in that that has that specialty in this area, and I have yet to find them.
Okay, well, there is one person, but we really don't know how good she is, but we've got a few guys who might be able to throw some light on that. There's another guy who is very good, but He's sort of part-time now, and I think he's out in Vale. Now, have you done any scan? Where's your PSA right now, currently?
Well, it was most recently taken, it was at a 0.2, and this was shortly after my last hormone treatment.
Okay, so right now, and how long is each shot that you're getting?
I don't understand the question.
How long is the Lupron shot that you're getting? Is it a 1 month, 3 month, 4 month, or 6 month shot?
I don't know that we look at it that way. We get the shot and then we watch the PSA,
Yeah.
and we're governed by the PSA rise.
Yeah. Let me explain to you. When you get that shot with Lupron, it's what's called a depot shot. They give you a certain amount. If you know the size of the shot, we can pretty much know how long it's for. That shot will last for a number of months. And then when it wears off, that's when your PSA is going to start rising. And now most people get continuous Lupron shots, and then they do intermittent, but they do it after a while. Do you remember when you first had the Lupron shot, how many shots you had before you didn't take another shot?
Well, I think my recollection is that the Lupron, that the protocol was I think I had 2 shots over a several week period, and then I didn't take it again for several months.
Yeah, that's unlikely. I don't think that doesn't really, back in 2015, probably not. You would have gotten a shot.
Well, no, the first one could have been Degarelix.
No, not in 2015, Herb. Highly unlikely in 2015. It was just coming in and it wasn't used that much.
Well, I
But
may
it
be
could have been.
misremembering. Maybe it was just 1 shot, and then it was several months while we watched the PSA
Yeah.
until I had another shot. And I've been getting roughly 6 months in between shots.
Yeah. So, I mean, I think there are a number of issues here, and some of it is just educating, helping you understand your treatment a little bit better, and what you're actually doing there. Have you ever had any genetic testing?
Yes, I did have some genetic testing.
And what did that tell you?
Well, I'm hazy about it. I think it told me that that this was not a genetic issue.
Okay. Any cancer in your family, Willis?
Not that I know of.
Good. Okay. All right. So I'm going to throw it open to the guys. They'll talk to you a little bit. I think everybody's got the picture. I think the fact that you got started with 3+3 disease or close to it is why you have been able to manage this so successfully for so long. And it's probably a good call that you're doing this intermittent.
Let me add one more fact,
of course,
because it's significant to me. My doctor has recently recommended that I consider adding enzalutamide to my treatment based upon a study that purports to show that this drug will increase the length of time that the hormone treatment will be effective and may increase the survival time. I'm currently in communication with the doctor about this because my reading of that study doesn't tell me that the enzalutamide is going to give me enough benefit to outweigh what I read to be the potential side effects from that medicine. So I'm right in the middle of that decision-making point as we speak.
We can help you with that. Actually, abiraterone is probably better to start with than enzalutamide, but there may be reasons why he doesn't want to give you enzalutamide, abiraterone, because it comes with a steroid, and you may not be a good candidate for a steroid. But we have seen better results adding abiraterone followed by enzalutamide rather than the other way around. That's the first thing. The second thing is, I think that if it were me, before I did anything different, I would allow that PSA to rise to the sort of level that you've been used to, maybe not quite as high. And then I'd get a PSMA scan, which is a detailed type of scan to see where the cancer is. Because there are other options. If we know where the cancer is, there are other options that we can implement. But anybody want to talk about the treatment, adding enzalutamide, giving some comfort to Willis in his path to date?
Willis, this is Peter. I back up what Rick just said. I'd ask the doctor about writing an order for PSMA scan. You can get that in Colorado, I'm sure, and it's very accurate. In my situation, which is lymph node recurrence, the first time I did it, it pinpointed exactly the lymph nodes where they were, and I went and got proton radiation, and it knocked it out. So there are other ways, as Rick said, to treat this rather than just managing it with Lupron. But you're fortunate that you've got a long ride, and you should be able to go for the rest of your life with this one. But
Thank
you might
you.
want to find out where it is.
I appreciate the advice.
Yeah. And in order to get a decent scan, your PSA is going to have to be higher than really 0.65. And if you let it get to over 1 or even 2, the way that your PSA rises, you could afford to do that. I shouldn't say, I'm not going to give you medical advice, but I think if it were me, I would feel comfortable. Then you should get a decent result, but you're not at a place where you can get that scan right now.
Understood.
Anybody have also any suggestions as to any medical suggestions, any doctors that they can come up with?
Well, there certainly is a GU oncologist in Denver.
Not necessarily.
Not necessarily.
Really?
There's that lady Elizabeth,
Right.
what's her last name?
Something.
Kessler. Her last name's Kessler.
Thank you, Don. So Elizabeth Kessler. Don, do you have experience with Elizabeth Kessler or not?
I do. She's, I mean, she's okay. She's kind of traditional, but not nearly as good as the guy I used to have that retired. But she's okay. I mean, you know, but she's not, she's very compassionate and, you know, knows her stuff, but very traditional. She's not going to do anything except by the books, which in this case might be fine.
Yeah. So there's one name for you. And who's the guy who's out in Vail, Don? That I know you get his emails. You're on his blog.
But I can't remember off the top of my head. But you'd have to go. He's actually, I think, in Craig, and you'd have to drive out there to see him. If it was complicated, that would be a good idea. But if it's, you know, if it's not too complicated, Elizabeth is probably fine.
I have a place in Vail, and so going to Vail is not a problem for me.
Well, Rick's, I can't remember, but I can find it. I'll find it, and I'll put it in the chat.
You talking about
That'd be
Michael
great.
Glode?
That's it. Who was that who pipes up?
Was I?
Oh, thank you, Ben. Yeah, that's it. Michael Glode. That's the guy. Glode.
That's it. Yeah, Glode.
Oh, Glode. Excusez-moi. Okay.
But that's it. That's the one. Yeah, you could Google him, and it'll give the little hospital he's at and stuff like that. I'd go to him. you got a place in Vail, I'd just go to him.
I think he
Thank you.
retired, guys, didn't he?
Appreciate that.
Didn't he
Say that
retire?
again, Lynn?
He retired from UC Health, but he's got his own, but he didn't really retire, and he's just working part-time, I think, out there, but he does prostate cancer. You know, he's great. At least as of a couple of months ago, he was still working out there, but he did retire from UC Health.
So, you know, I think that there's a lot of quirks in how to proceed. Not a lot, but there are quirks in how to proceed for you, Willis. But you've had such great success with the simplest of treatments that you should be highly encouraged. Should you add another? I mean, I think the first thing I would do is get a good scan. The second thing I would do is get a really good specialized prostate cancer doc like Glaudet, or going to see Dr. Kessler, who's at in the University of Colorado system. And
Well,
then
I appreciate those thoughts. My philosophy is that as long as I'm doing as well as I am, I'm not anxious to add things that have significant side effects, because quality of life is more important to me than quantity of life.
I think that's why we're saying to you, you've got to know more about where this cancer is coming from. Because it's clearly in, you know, another option might be to do more radiation, spot radiation to the places where it's coming from, and do that in conjunction with the Lupron. But we just don't know yet. I mean, the one thing that you don't want to do is to let the disease get out of hand, and just by monitoring it with PSA, that could be tricky. So you really need to do more, get more information, and what your doctor's telling you is very much where the guidelines are right now. Nowadays, they don't just give Lupron alone when your disease comes back. They give Lupron plus another drug. Whether the right drug for you is abiraterone or enzalutamide or apalutamide, not sure. But I understand why he's suggesting that to you, and we can help you decide what the side effects are, what they might be when you get closer to doing something. But for me, step one would be get a good scan, and step two would be to get somebody good to look at that scan with you and who's specialized. Anyone else want to add anything to this?
Yeah, sure. Like, Willis, I was just gonna say, like, if you have just if you do the scan and it comes out with oligostatic, which means like 2 or 3 sites in your lymph nodes, modern radiation is really good at zapping that away, and it's very successful. So put that on your things to check out, please.
I will, thank you.
Rick,
Yes, sir.
this is Jim Marshall. I was curious, doing, intermittent Lupron, is there a case for testosterone flare? In other words, is it being covered?
You know, that's such a good question, Jim, and it's something I've thought about a lot. I mean, it always seems to me that if you're going on and off testosterone, if you're going on and off Lupron, that every time they put you back on, either they should put you back on with Firmagon, or they should give you bicalutamide before they start. But I don't think a lot of docs do that. If it were me and I'd been off for a while and I went back on, I probably would want that. I mean, Len, you've been on and off probably more than most of us here. And now I know you're doing the monotherapy, but did they ever put you on bicalutamide, or did they give you Firmagon for your first shot?
Yes, they always put me on bicalutamide before they restarted Lupron, because
Okay.
my T levels were very high. I
Yeah.
suppose if your T levels are low, even though you're on drug holiday, there may not be much of a need
You're
to
right.
first get a hormone receptor blocker.
Right. But I mean, this is a great point for everybody, that just be aware that if you are on intermittent and you're restarting Lupron or an agonist, one of the agonist drugs, that you probably do need to take a buffer. And if you're restarting with an antagonist like Firmagon or Govix, then you don't have to worry about that. But Jim is right; it should be on your radar.
I never did it in my situation, and I went on and off at least 4 times. I'm off now, but it was never, other than my initial shot of Firmagon and bicalutamide 8 years ago. I've never done that. No, but I monitor my T levels every month. So I keep an eye on that.
So can I ask the question of, in this intermittent situation, wouldn't Orgovix be a better choice?
Yep, it would. It would be a much better choice for sure. You're right, Herb. I mean, Orgovix, Willis, is a pill that you can take, and it's in place of the shot, and it has some benefits. We don't really have time to get into them right now, but certainly, when you go back on, you want to talk to your doc about whether you're a good candidate for the daily pill as opposed to the monthly, the shot, which would have a lasting effect of 1, 3, 4, or 6 months, and we don't like the 6 months either.
Orgovix is pretty expensive, and the shot is covered by Medicare.
Well, but the Orgovix is starting to be covered by Medicare too, Steve. We're seeing people getting it now.
Can you
Well,
spell
my
that
prescriptions, I
medication?
turned it down.
Spell that for me. How do you spell that medication?
Orgovyx.
Thank you.
So yeah, I mean, we know some people have problems, but others, some are getting it, some are not, and it seems to be more and more frequent that they're getting it. And also, you can work with the Myovant, who makes it, to try and get it if you get turned down on it.
There are
But
scholarship programs, right? I'm working on one.
Right. So let's move on, because I want to make time for you, Steve, and we've got one other new gentleman that Peter, would you like to? Yes.
It's John. I just wanted to interject. There's discussion about getting a PSMA scan. I'm aware that that's not always covered by insurance. At least I'm on Medicare, and the Medicare and supplement that I have will not cover a PSMA unless it is for if you're non-metastatic and you're trying to determine if you are metastatic. But somebody like myself, I've been metastatic for a while, I'm understanding I can't get it covered by insurance at this point in time.
That's not right, John. It's approved. It was FDA approved for both cases, both for metastatic and for people who are not. So, I mean, somebody here can look up the FDA approval, but when the Pylarify was approved, the 18F DCF PYL was approved. It was approved for metastatic, and we've got a lot of guys on here who are getting it under Medicare. So I
just had it approved in the last month.
Right.
And I'm
Okay.
metastatic.
Somebody's giving
Wow.
you the old runaround there, John.
Yep.
Who is it that's telling you?
My doc, UT Southwest.
Yeah, I think you
My
need to
doc
go
told me
back to
the
him
same thing. And got it.
it's approved.
Okay.
I mean, I'm 99% sure it's approved. And you know, you could look at the Pylarify approval. I don't have time to
Yeah. I'm looking at it now.
Yes. Okay, we'll come back to you, Herb, because I don't want to take time.
Yeah,
We've
fine.
got to
No
we've
problem.
got to keep rolling, but post in the chat window what you see. But I'm almost certain that the Pylarify is approved. Okay. Let me get another sheet of paper here. And
Did we answer your question or any of your concerns, Willis?
Yes, this has been extremely helpful. This is a very knowledgeable group of guys. It's great.
yes, many of these guys have the T-shirt, and that's how they got knowledgeable, Willis. All right, Peter, would you like to introduce John? John, can we hear you first of all? Are you there? We can't hear you. Your microphone is on, but we're not hearing you. So,
Yeah.
Is that you? Speak up.
This is me. This is Peter. While John's trying to figure that out, I'm going by memory here. So John, if I'm wrong, correct me, and I'm sorry. John came in our low and intermediate meeting last week or 2 weeks ago, whenever it was, and he was first diagnosed with a Gleason 6, and he did all the right things, and then I can't remember whether he had a second biopsy or something was going on, but he sent away to Jonathan Epstein for a reading, and Epstein found a 4+5 and a 5+4 lesion in him. So that jumps it to a Gleason 9. So he's got an odd situation, and it's probably good to follow up on Willis's thing because you don't always trust the Gleason 6 diagnosis. So maybe it was a wrong diagnosis at first. Maybe the biopsy was blind and didn't catch stuff, but whatever. But I suggested John come into this group because of the Gleason 9 reading.
So, John, can we hear you yet? All right. Go to your settings, which is the cogwheel in the top right-hand corner if you're on a Mac, if you're on an Android. Sorry, if you're on a PC. And click on that and make sure you've got the right microphone selected. Because you may not have, you may have it on, but you may not have the right microphone.
How's that?
That's great. That worked, eh? I hope we can do as good with your prostate cancer.
Okay, I'm not sure what happened there. Okay, I'm ready for the questions. Your age and all those things.
Okay. So, how old are you?
74.
Okay. And where do you live?
I live in northern Kentucky. I can see the Cincinnati skyline out my window.
Okay. Northern Kentucky near Cincy. Okay. When I assuming you must have been diagnosed pretty recently.
Late 2020, I had the MRI guided transperineal biopsy that found a high volume of Gleason 6.
Okay. And we're very impressed that in late 2020 you had a transperineal. You guys, whoever your doc was, they were well ahead of the game, unless it was you advocating for yourself, which is impressive.
It was
Good
me
for
advocating.
you. Good for you. Now, what happened then between late 2020 with a high volume Gleason 6 and April of 22.
Well, earlier this year, back in early March, I had another MRI and another transperineal biopsy. And this is the University of Cincinnati, a pretty big hospital there. And their pathologist came up with some Gleason 6s, and they found 9 7s. I went to Hopkins for a second opinion. They downgraded 6 of those 7s to 6s. 1 stayed a 7. They upgraded 1 to a 5+4 and another to a 4+5.
Okay, hold on a minute, because you said you had a bunch of 6s and 6 7s. Were those 7s 3+4s or 4+3s?
Combination of 3+4s and 4+3s.
And you're saying that of those 6, 4 went down to a 6.
6 of them actually. 6 actually went down to a 6 per Hopkins.
Okay. So 6 went to a 6, and then there were 2 more 7s.
One stayed at a 7.
Yeah.
And they upgraded 1 of the 7s to a 5+4 and another 7 to a 4+5.
Okay. Well, I think there's a. And how big were the 4+? How long were those 4+4 and 4+5 and 5+4?
The 4+5 involved 20% of one core.
And how long was it though? That's the problem, is when you talk percentages, it only means anything if you know how long the core is.
Oh, okay. Give me 1 second here. I got 2 reports. They really don't say on either report how long the core was. It was grade group. The local one was grade group 3, 80% pattern, involving 1 core and approximately 7%. Carcinoma measured 1 millimeter at greatest extent.
Say that last thing again.
The carcinoma measured 1 millimeter in greatest extent.
Okay, what did this? Was that in the 5+4 or the 4+5?
That's the 4+5.
Okay, and how long was the greatest extent in the 5+4?
Oh, give me 1 second, please. That was.
Just a heads up to Joe Gallo. I'm bringing you in next, Captain.
Okay, that other one was a 2.5 millimeter.
Okay, so that's kind of important, because it's telling us that these little pieces, even though they're serious, they're very small. They're negligible, of a negligible size. They've got to be treated, but they are of a negligible size.
Okay.
Joe Gallo, you want to just share? Did you talk to John on Peter's call, first of all?
Actually, Peter did a great job with him, so I didn't really have much to jump in on.
Okay, well, give him a very quick resume of where you are, and tell him what you would do next in John's shoes, and then we'll throw it open if anybody else has some.
I've got one thing first. I did have a Pylarify PET scan 2 weeks ago.
What's your PSA right now?
Please?
What is your PSA right now?
The last time in November it was 9.02.
Okay.
Oh, and both pathology reports did show that I have peroneural invasion.
Right.
And 2 weeks ago I had the Pylarify PET scan. And it shows that it's still confined to the gland.
Okay, that's good.
Which is
so, Joe, speak up, man.
Well, I would have suggested the PSMA PET, but he's already done that with the Pylarify. And with that indicating that he doesn't have anything outside of the gland, I think the key thing there is to find himself a good med-onc who can help him guide through. Even though he has a number of cores, he conceivably, because most of them are sixes and a few are sevens, that he could look at alternative treatments like whether SBRT or even radiation. I don't know that he's necessarily indicated for surgery just at this point.
Joe, I do have 2 9s. That Hopkins upgraded 2 of the 7s to 9s.
Yeah, but what Rick was telling you is that they were very small.
Okay.
Which means they can be treated. I have Gleason 9 as well, and I went the radiation route, and with to this point, it's good success. Following up with ADT, so I'm on the hormone therapy.
Joe, on the topic of radiation, to complicate things, I've had several bouts of diverticulitis over the years. I've had 2 back in January. I saw a surgeon who said that if I had radiation, she could not do a colon resection because the radiation weakens the wall of the colon and would not heal correctly.
Again, a good rad-onc would be the person, somebody who is at a center of excellence to really explore that. There's a couple of choices, one of which is the external radiation. The other is the SBRT, which is the short course of external radiation. And in your case, they might even want to consider brachytherapy.
Yeah.
They could, that's focused. It's totally internal.
That was my thought. Maybe HDR and ADT if needed.
Well, I think where it gets complicated is this, that when you've got a lot of cancer, which you do, even though most of it seems to be 6, HDR is preferred. So you're probably set up really well for HDR. The problem is that we know that when you've got 4s and 5s, even only a little bit, that you really need additional radiation outside of the gland, which is where it would get complicated for you. And I think certainly a good radiation oncologist who specializes in prostate cancer and or even consulting with a genitourinary medical oncologist because of this complication as to whether you could do additional ADT without doing the pelvic girdle radiation is a discussion worth having. That's what I would say. Is there anybody in the group who?
I agree with that, by the way, Rick. And especially since he doesn't have any Mets that are showing. It's showing everything is capsule contained. Yeah. That would be a good possibility.
Yeah. And I don't think you're a great. I would say if it were me, I wouldn't be doing surgery because I don't think surgery is a really great option once you get over the age of 70. It's really, really hard on your body. And as good a shape as you are, I always flinch when I hear men over 70 doing surgery.
Okay. So, I do meet with a surgeon tomorrow from a for-profit group, and I know what he's going to say. And next week, I meet with a urologist who is also a medical oncologist. And I'm also meeting with a radiation oncologist at the university.
Hold on a minute. Let's first of all, let's take the guy tomorrow. You want to ask him how many men over 70 has he treated in the last 5 years and what have been the complications?
Okay.
Because he's going to tell you he can take care of this and you're going to say to him, "What? Yeah, but I'm over 70, man." That makes a difference. And if he says, "No, it doesn't make a difference," for me, he wouldn't be the right urologist if he doesn't recognize that.
Okay.
Secondly, you say you're meeting with a urologist who's also a medical oncologist.
Yes.
Is he described as a urologic oncologist?
No, he's a urologist / surgeon / medical oncologist.
Okay.
I don't know.
What's his name?
Dr. Sadana at the University of Cincinnati.
Right.
Could you spell it?
Sidana.
Sidana. Highly unusual, and let me explain why. Because the surgeon goes through medical school on a surgical track, and the medical oncologist goes through medical school on an internist track. And I don't think I've ever come across a surgeon who's repeated medical school and gotten a qualification in internal medicine as well as surgery. Now, there are a lot of surgeons who think that they can treat you as a medical oncologist, but they're not qualified to do it. So I think you've got to drill down real hard on this guy and find out what exactly his qualifications are.
They're on the web. They're all urological surgery. They're first-rate urological surgery, but they are urological surgery. He's had no medical training.
Okay.
Just to give you a heads up.
Okay, thank you.
The clue I got is when they put the medical oncologist as his third specialty.
Yeah. So you don't want to be seeing a doctor like that to treat advanced disease, in our view. That's our view. That's an AnCan view. There are urologists who will disagree with us, but we have enough evidence to see where they've screwed up in the past and where they've sent their patients to other specialties when they should have been able to take care of their patients. So we don't love it, but and we would advise you strongly to get, I don't know if there is a GU MedOnc in Cincinnati. There certainly is in Columbus at the James. And we can give you names at the James. If you want to go up there for a consult or a second opinion.
Okay, if someone could give me the name for someone at the James, I appreciate it.
Well, the guy that I like, who the heck sees him? Okay, there's a couple of guys. I got to think. Frank, where's Frank? You still with us, Frank?
Sure am. Yes, the doctor at the James is Dr. Mortazavi, Amir Mortazavi. And I've been going to him for the last year and a half and would highly recommend him.
Okay, could you put that in the chat box, the spelling?
Sure will.
But I appreciate it.
Okay, the other guy that we know, but I would choose Mortazavi, but the other guy that we know, his last name is Monk. We know a couple of people that are seeing Monk, but I think I would choose Mortazavi if it were me.
Okay.
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 So, anything else? Because I'd like to try and get to Steve and to give him some time as soon as I can.
Well, he should be able to, he's having 2 meetings now between now and our next meeting, so we should then have some more input.
Yeah, come on back, John, and, dig down with that radiation oncologist. Make sure he does HDR. When you walk in, the first question you want to ask him is, do you do high dose brachytherapy? If he says no, but I'm very good with IMRT, and he may not be the guy you want to see because you may not get an independent view from him, especially if he's in a community for profit practice.
Well, this radiation, well, there's a radiation oncologist, University of Cincinnati. His name is Dr. Barrett. And there's a Barrett Cancer Center there. And he does HDR, I've been told.
Okay. Okay. As long as he does it or he can offer it in his practice, it's fine. It's where they can't offer it in the practice that we get a little nervous, because then they discount it.
Okay. And I didn't realize they do that through the rectum.
No,
They don't do it through the rectum. They do it through the perineum.
yeah, it's a perineum.
Okay.
And it's an insertion of rods. And the benefit of it is that they can very particularly place each one of the rods before they give you the radiation. That's the benefit, especially in like in your condition.
Okay, and it makes no difference as to the number of lesions a person has?
Nope.
Okay, great.
In fact,
But just be prepared. You're going to be there the better part of a day.
And this guy Barrett has done a fellowship in brachytherapy at Memorial.
okay.
Oh,
So he
who's
could
done
be
that?
your guy.
Oh, would somebody repeat that? They're saying Barrett did a,
Barrett, the radiation oncologist, has done a fellowship in brachytherapy
okay. Well, thank you.
a long time ago, but I think he knows what he's doing.
Okay, guys, I'm gonna cut it off right now, only because we've really got to move on. And John, come on back. And Willis, do we have your email address? If not, can we add you to the reminder list, and so you get a reminder before each meeting?
Yeah, why don't should I put it in the chat?
That'd be great.
Okay.
Fantastic. Thank you very much. Okay. We're moving right along, and we're going to start with Mr. Saft. Steve, I know more about you than the most, as does Herb. So why don't you bring the guys as quickly as you can up to date and tell us what's on your mind.
Okay. Over the last month, I have been to Houston to see Dr. E. She's known here. And it was determined that my cancer disease sets up nicely, or appears to set up nicely, I guess is the right way to say it. There's no guarantees on anything for the lutetium treatment, which is now called Pluvicto. It was approved, and as luck would have it, that means that it's going to take some time, it looks like, to get approvals for Medicare and for who's going to run it at every particular hospital. And Rick has been doing yeoman's work and others in the group to find out where it's going to be first. The most optimistic version I've heard is plus or minus 4 weeks. So having said that, my cancer has really not responded to anything through 3 different treatments. The ADT, then I did a clinical trial, then cabazitaxel did slow it down, but it didn't stop it. And over the last 45 days or so, I've been trying my best to get enough diagnostic work to see what would work best, so as not to be put into some trial that has a very small chance. Having said that, on the side, there's a lot of stressful things going on in my family, including a new one that my 96-year-old uncle, who I'm very, well, first, my wife is having a double mastectomy on Friday. My 96-year-old uncle, who I'm very close to, fell yesterday, broke his hip, and I spent a good deal of last night in the hospital with him and this afternoon. And he is undergoing surgery as we speak, which is high risk by its very nature. So the stress level is high. At any rate, I would like to get the lutetium, the Pluvicto treatment, but it doesn't seem like it's coming through fast enough. And last week when we heard about it, people were saying 4 to 6 months. And so I have a friend that is a medical oncologist at Weill Cornell, and I have been accepted into a clinical trial that they're still running, which has the LU-177 plus actinium-225 combination treatment, and the actinium makes me and several other people here nervous. But I think at the moment I'm going to go ahead with it because it's the best chance I have to get a treatment that has a decent chance to have an effective treatment, as opposed to most other things at this point they're saying are maybe 10 to 15% chance, which would be very lucky. So the update is I believe that I will be, they're looking at all my films at Weill Cornell tonight, which now include a Pylarify, an FDG, and a gallium-68. My understanding is that they kind of all need to set up showing, confirming each other's PSMA expression for me to be a good candidate for these PSMA treatments. I can tell you that the actinium and the lutetium are an alpha and a beta, but I don't really know what that means, so it's sort of silly for me to talk about it.
So let me jump in, but just to edify the group a little bit, and I'm not the expert, but the actinium is a larger alpha particle that goes deeper and is a lot stronger, maybe as much as 7,000 times stronger than the beta particle, which is more of a shotgun approach with lots of little ball bearings that sort of spread out. And the beta is lutetium and the alpha is actinium. Now, we know quite a bit about lutetium. We don't know as much about actinium other than the fact that we've known a couple of people that have gotten actinium, including Carl, but Carl only got one treatment of it. And really that treatment was more, not so much to cure the cancer or to address the cancer, but it was to try and turn all of his lesions into hot tumors so that the Keytruda, the pembrolizumab, would be more effective. It didn't work for Carl. Now, with the actinium, we know of one guy who got actinium and he had significant side effects from it. He got it from Tagawa in a trial.
Tomorrow afternoon.
Okay. So, and we've hooked Steve up with that guy, and he's going to have some opinions. But again, as I've warned Steve, you've got to look at the dose that he got, the dose that Steve is going to get, and how that compares, because it may not be comparable, just the same way as Carl's experience probably isn't going to be comparable with what Steve is doing. What bothers me is that when they mentioned actinium and side effects at Weill Cornell, Steve mentioned it to him at my prodding, and they kind of discounted it. They've never known anybody have any issues. Well, that might be under a different protocol, which is a fair enough result.
And it might be a research nurse that doesn't know enough, and I'll ask more tomorrow when Cora's back in the office.
So, Steve, do you have, before I throw it out for other people's comments, do you have any questions you want the group to consider?
Does anybody know where I can just get the lutetium by the 14th? So,
I do have to tell you, Steve, by the way, that Oliver Sartor stood us up yesterday. And so Brad Power decided to close the meeting, and I haven't heard from him today. But what he had said, Sartor had said to Power that they were 4 weeks away from delivering at Tulane. And that's the best information we've got from anybody, because
So
we still don't have any feedback from Mount Sinai, UCLA, or Chicago.
now Dr. E said that she thinks somewhere in Houston they're doing it privately. But I don't know what that means really, and she
I
didn't
think
really
it
explain,
means, well, I think that means you pay the list price.
which is above
42,
$300,000 from what
that's
I understand.
42K per cycle from billing from Novartis.
Well, I mean, obviously, I'd like somebody to look into a crystal ball and tell me what the future brings over the
Well,
next
I
2
mean,
weeks.
well, Steve, as I told you,
Right.
looking at the doses of what you're getting, the dose of lutetium is exactly the same as Pluvicto. Okay,
Right.
the radiation level is exactly the same. The actinium is much, much less, a lot less in terms of radiation exposure.
So hopefully it's not toxic, but again,
Right.
I have more
But
questions.
I think the fact that it's much less is, to me, very good. A good
The other
sign.
thing that she told me, Rick, is that it's the same dose in both treatments that are scheduled. And the implication was that they've settled on this dose after experimenting with dose escalations at lower levels and higher levels. Again, I want to confirm that, but that's the way I understood the conversation on Friday.
What phase trial is this?
I'm sorry?
What phase
Phase.
trial?
Oh, my understanding is will be the last of phase 1, and that after this is phase 2 is going to start with whoever's the next patient. That's the other thing she told me.
And that means that Steve has to make weekly visits to Weill Cornell from Philly for tests.
Well,
Steve?
just weekly visit, right, for labs, just to get my blood taken.
That's right.
You don't have to, will you have to go up there for labs?
That's what they told me, that's the way they run the clinical trial. Listen, I used to commute to New York for work every day for years, but I don't want to do it again. I'll keep working on that, but for the time being, listen, and look, if it really can help and it's really given me the best chance,
Right.
it's not that huge a price to pay, but it is a pain in the ass. Like, why can't somebody, take the blood and do the CBC or the CMPs down here? I don't know how much different it could be, but we'll work on that. For the time being, I think with the way my cancer has been progressing, and I sort of feel like it's on the move again over the last 2 days. I've had a little bit of tingling every once in a while when I get up from sitting down. So, I obviously don't know what to do, but I think my best bet is to try this. And if it is toxic with respect to my liver, I think that I can take one course of it and then hopefully get into a program with the LU-177 after that.
Yeah.
So,
Steve,
I mean,
Steve,
think of it this way,
Steve?
Steve.
yes, right.
Go ahead,
Steve,
Peter.
regarding your stress levels, are you the primary caregiver for your wife going through this, or do you have other family members there?
My daughter and my son will be coming back for this, but yes,
Okay, so it's not going to fall on your shoulders to care for her. You got a lot going on in your life right now. So
that's a fact.
Yeah.
Yeah, and I think that Peter
As
makes
does
a
she.
really good point that Steve, I think if it were me, I'd be going out of my way to make sure that the caregiving duties for Ellen are acknowledged and assumed by the kids. That you don't want that you want them to be number 1 and number 2, and you'll be number 3, but you got enough to handle yourself. and only you can do that. But I think that's what you're hearing us saying here. We want you.
My
We
point
really
well
want you.
taken. You
Okay.
know, it's like, it's not my personality to do that, but I'll make myself do it.
Okay. Herb, you had something.
So, I mean, well, what I was going to say is the dose is scheduled 4-week intervals. The Pluvicto is scheduled 8
Oh,
weeks.
I'm sorry. You're the lutetium, right? The Pluvicto is 4-week intervals.
No, Pluvicto is 6 weeks.
6 weeks.
This is 8 weeks, Herb.
This is 8
Right.
weeks.
But this is 8 weeks. So that means you'll have plenty of time to see what's happening after your first dose before you have to have a second. And by the time the second dose is ready, Pluvicto will be ready as well.
Oh, I mean, that's where my head is at. And I think that I really can't afford, I don't want this to be a double negative. I have to try this. Let me say it positively.
Right.
I agree. I think it's you go with a small dose of
I'm gonna say, unless anybody, I'm just looking at the number of people we got, and I think we're all agreed on this.
Okay.
And is there anything else, anybody who hasn't spoken that has anything they want to say to Steve before we move on to Brian?
Yeah, I just wanted to quickly add, when I was on that actinium, enzalutamide, and Keytruda trial, also Weill Cornell, I clearly remember the disclosure document specifically for the actinium. And because it is radioactive, and as Rick said, it's several thousand times more potent than lutetium, it's somewhat, you take a step back to see the side effects of that particular drug. But look, hey, you take a chance.
Well, you got sick, but Carl, did you have liver issues or did you have a number of other issues?
Well, the hemoglobin levels went dangerously low, and I had to get some infusions, but I think the liver enzymes were okay, from what I recall.
Interesting. Okay. All right. Well, thank you very much. And, obviously I'll keep everybody informed because I think it'll be educational, instructive for all of us.
And Steve, bear in mind to check with them about using public transport going back and forth, because there may be issues around that too. Okay, so right after the infusion.
Yeah.
Well, right. And whether I'll be able to drive or I'll have to get somebody to take me.
Yeah,
Or you can drive.
You can probably drive. If you're going to drive up and back yourself, you'll be okay. David Muslin, you had your hand up.
Yes. So I understand the trial, but if you go into the trial, will that slow, and all of a sudden you find a place where you can do the lutetium, could that possibly slow you down from doing the lutetium, doing this trial? And will you have the strength to go right into that?
Well, I guess the other question is, they want me to clear my system of the actinium, and how long does that take? Those are questions I have to ask, because I would think it's a problem to start lutetium by itself in a different program. But yeah, those are questions I'm gonna.
Right, and then coupled with that, Stephen, how important is it for you to be present for your wife while she's going through what she's going through?
Well,
and you've got a lot of balls up in the air at one time.
My son is coming home for at least the 2 weeks, and my daughter is 20 minutes away, and we'll get it done.
Okay.
But I do have to ask and make sure, like, everybody's used to counting on me, so we just have to make sure that I back off a little bit and everybody else steps up.
I get it. Take good care, Steve.
Steve, what did you say your rate of progression was of your disease right now?
I don't know how to quantify it other than, I did start went back on abiraterone, which I already failed, and my PSA came down, but ALP and LDH have gone through the roof. One's ALP 730 and LDH broke 1,000 the last time I had the test a week and a half ago.
How are the scans? Are the scans steady?
The scans are showing, so it's only tonight that they're going to be able to look at comparisons before, because I sent them all the discs. I had given them to them, but they misplaced them. And so, but clearly the disease is, is moving forward. So just by the language of how much and where the disease is in a couple of the tests, it's clearly my metastatic disease is moving forward. It's not staying the same.
I guess
Right, guys, we got to move
Rick,
on.
I could just interject, and Rick, I've been talking to different doctors. I went back to one that I've got a lot of respect for, and she cautioned me that, you don't always have to be under treatment. If, sometimes the worst thing is to get treatment and it isn't the right thing. And Steve, it certainly sounds like he's analyzed it, but I think the gentleman before him asked some good questions about, to do this trial may be apparently, a good step to go forward, but it may slow you down in the lutetium. I think that's
Possible.
a consideration.
I'm not comfortable being without systemic treatment. That has a good chance. So.
Okay, that you've crossed that bridge. That's fine.
All right.
Okay, guys, we're moving on.
And I thank you all very much. I got to go too. Talk to you soon.
Okay. Brian Davenport,
Yeah.
bring us up to date, and my apologies for not having seen you early on.
No, Rick, you got a full plate. I understand. I've just finished my 8th cycle of cabazitaxel and carboplatin, and this is after 3 years ago doing doxycycline and having a successful about 18-month period of no progression. But then I went into a clinical trial for 4 months that when progression started at NIH, I came out of the trial, abiraterone and enzalutamide, neither one had any effect. And so that's why I started with the cabazitaxel. My PSA is negligible. It's like 0.12. I'm going this week. I've got a CT scan today. I'll get a bone scan on Thursday and an MRI of my abdomen on Friday. And that will really dictate how well has the cabazitaxel and carboplatin done going forward. I asked the doctor as to what is next, and I get the impression that that after this, I am a candidate for the lutetium-177 at some point, but like every other hospital, Walter Reed is working to get the capability, but it's ranged from 4 weeks to a year, somewhere in between maybe. And part of it is the new expense that will come on and the budgetary procedures and those types of things. But my question really is, my oncologist feels that I would probably stay on cabazitaxel, maybe come off carboplatin, and maybe have a lesser dose, because what has happened after 8 doses is that my platelet count has begun to be impacted, where at one point it got down to 57, and they had to wait an additional week before I could do the get it back up to the 200s. My last time I had 105, and they went ahead and were able to still do the chemo on time. But it looks like once you start down this path, you don't get off the chemo until it's no longer effective. And I just wanted to see if that is the thought process of anybody that has gone that far downstream in this process. And And he indicated that it might be a lesser dose to try not to have as much of a side effect, or it could be a longer cycle time. Instead of 3 weeks, may go into 4 weeks. And the carboplatinum being, that might be moved out, and it might just be cabazitaxel. But at some point, it's not going to work. And then that's where I'm so grateful that the lutetium-177 has been approved. But that's my situation. And any comments would be great.
Yeah, I'd like to pick on a resident expert in our midst here, Mr. Birch. What's your advice to Brian in terms of continued chemo in the face of the disease retreating and with cabazitaxel and carbo? What speak to us?
I've got experience, Rick, but I don't have the answer for sure. I'm a lot where I'm in a very similar situation where he is at. I went 27 rounds of docetaxel, and over about a 2.5 to 3 year period, and my counts stayed fairly steady, which was encouraging. The PSA kind of bounced around a bit, but started to, at the end of that, go to a more of an upward trend. Not radically, but I'm also, as you know, I run a pretty high PSA, a very high PSA compared to a lot of the folks on the call here. I did 5 rounds of cabazitaxel, and my last was at the end of January. I stopped so that I could be in shape for my daughter's wedding, which happened a couple weeks ago. Got through that in good shape, but I have made the decision now to go slow on cabazitaxel, pending trying to get into lutetium or several other options that Dr. E and another doctor at Sloan Kettering are kicking around right now. So it's kind of a jump ball. You know, what do you do next? But at some point, the chemo just beats the hell out of you from, if not a mental standpoint, certainly from a count standpoint. And I understand, you know, what he's saying about his platelets going down. My hemoglobin is taking some dips, but I think it's a little bit on the up curve now. So, you know, part of it is trying to get yourself set mentally and body wise for the next whatever treatment there is.
Who else has done, is there anyone else who's done serial chemotherapy that might have any words of advice for Brian? We don't have Ken Anderson on here today, who of course is our other long-term guy.
Well, I appreciate John's comments. And Rick, I am going to see Dr. George the Monday after Easter, and so I'll get his assessment as my quarterback, if you will, going forward. But I appreciate that. I know there's a lot of other people on the call, so I can work with that. Thank you.
So I just want to, first of all, I want to say that we think you're in great hands with Dan George. We go back, Len and I go back a very long time with Dr. George. He treated a very dear friend of ours. And he's a really good guy. And I actually had correspondence with him this week on behalf of your buddy down the road, George Denyon.
Great.
Brian.
Wonderful.
And so I think that really, I think you can rely on his advice. It's probably some of the best advice you're going to get.
Yeah.
And he can give medical advice. We can't give medical advice, but Dr. George can give medical advice. So please send our regards to him. Be sure to remember us to him. We really appreciate him. He's always caring when we reach out to him, and we so appreciate that. and let us know in a couple of weeks. Oh, and push him on when he's going to have Pluvicto available, because he's told Jerry Deans it's going to be pretty quickly, but they weren't doing the managed access. So we're really interested to hear, and also you can offer our condolences on Duke. So that's it.
All right. I will do all of that. Thank you.
Okay. I want to stay on the lutetium track, and we'll go to Herb.
As you know, I was scheduled to get lutetium, and then they called to tell me that the compound wasn't up to snuff, and so they delayed my lutetium. They delayed it to a week ago Thursday. And so I get a call the day before, and the story is just interesting, so I'll tell you. Get a call the day before, they're ready to go, show up Thursday morning. Thursday afternoon or Wednesday afternoon, we get the approval. So I go up to Hopkins, they're all ready for me. I get the injection, and then I find out that the trial is closed. So I think I was probably the last person getting it under expanded access to start. I mean, they don't cut you off, luckily. I'll still be able to get the rest of the doses. And the first person to get it after approval. So far, so good. I brought home a Geiger counter. I was started out as hot as you could possibly imagine, but it's dropping. But I'm still hot. So not so hot that I can't go near people or have to take precautions, but I know that I'm radioactive. So, but otherwise, I haven't had too many side effects, maybe a little bit of dry mouth, which I'm noticing, but not severe. And maybe in the first few days, I was a little bit tired. I was starting to take naps, but that seems to have gone as well. So hopefully, I mean, that's where we are. The interesting thing is right before starting this, after having Provenge, my PSA started to drop. So it went from 5 to 3.2 something. And so that was interesting because Provenge isn't supposed to touch your PSA. So we'll just have to see what lutetium does.
So one thing I would like to just remind everybody who is thinking about doing a theranostic treatment, that it's likely to affect your esophagus, because the esophagus cells, the esophageal cells do express PSMA. And there is, and I put it in the reminder, there's a webinar on Wednesday, I think it's at noon, by the dental health group at USC, focusing in on cancer. And it might be a really good question to think about as to what can be done with these theranostic treatments to help people who are going to suffer with dry mouth, et cetera, et cetera.
So let me interrupt, Rick, and say that there was an article that just came out in the NIH Bulletin talking about a clinical trial of a gene therapy which regenerates salivary glands. And it's open, evidently it's open to people who have salivary gland issues. So we'll have to see how that trial goes. But it looks quite promising from the point of view of people with salivary gland issues.
Okay, are you eligible or are you not eligible?
Well, I'm not eligible yet because I'm not bad enough, but if I get bad enough, boy, I'll be at their doorstep. And let me tell you one other thing that I did talk about, and this is again not me. I listened to a incredibly interesting talk, which you can probably listen to on the NIH website by Steve Rosenberg. For those who don't know Steve Rosenberg, he is a surgeon at NIH who's essentially single-handedly carried forward immunotherapy with something called tumor-infiltrating lymphocytes. And the talk was stupendous in terms of the kinds of results that he's getting in solid tumors. And thus far, he's treated one prostate. So I would say look for advances there.
Okay, we're gonna, anyone else for Herb, or can we move on? We're moving on. And we're staying still with lutetium, and we're going to Al Latimer, who is our lutetium warrior, because he's finished his treatment, right, Al? Are you there, Mr. Latimer? We can't hear you. Your microphone's on, but we cannot hear you. But we could hear you before. No? Okay, we'll come back to you. Check that settings thing like John Schukter, and we'll try and get back to you in a minute. And I think at this point we've exhausted all of our lutetium candidates. So we're going to go to David Marcelin.
Okay, thank you, Rick. Just a quick update. Been checking my PSA and my T level every month. Did it last week. PSA is still undetectable, and my testosterone is finally on the rise, kind of what we thought there, Rick. And it's at 250. So today I started darolutamide, taking 1,200 milligrams a day, both with food. So I'm all excited to be on darolutamide.
Okay, so
that's the update.
So your PSA hasn't moved.
Nope.
Your testosterone is at 250.
Yep.
Any reason why you decided to start the darolutamide before your PSA moves? What was the thinking there with Dr. Shmulewitz?
So Shmulewitz said, if the PSA, once the testosterone gets above 50, you start the darolutamide.
Okay.
And so it was based on only the testosterone rise. So it bumped up from 0 a month ago to 250 today. And so I'm on the darolutamide.
I'm glad it wasn't 250 when I visited you. You might have thrown me off the boat.
Maybe. I mean, now for sure you can't wait till it gets to 500. I may throw you over the boat.
Oh my God. Oh my gosh. Anybody who's on darolutamide, we have a couple of people who are or have been. Any words of advice for David now he's starting the darolutamide?
David, this is Len Sierra. I think I heard you say you're taking darolutamide with food.
Yes, that's what the prescription says.
Really? Okay, because
yeah,
I thought it could be taken with or without. I mean, I took it with meals anyway, so I guess it doesn't matter. But all right, if that's what the package insert says, then I guess you're good.
Yeah. How much are you taking? How much do you take, Len?
Well, I'm not
milligrams a day.
I'm not taking any at the moment. For the last 3 months, I'm on complete drug holiday. But yeah, I took the full dose of darolutamide for I think it was about a year, and then I cut down to half the dose, and then I cut down to 25%, and then I just cut it out completely. So, it all depends on what your PSA level is doing.
Yep. Okay. My PSA is undetectable, and I'm following what Shmulewitz said, and I sent him a my chart note last night, told him what was going on. He said, yep, go ahead and get on that, and we'll check in 30 days.
Well, the experience with Peter and I is that we did feel fatigue from darolutamide, but we didn't have the mental fog. We didn't have any cognitive deficit. So, you know, don't be surprised if you do feel some fatigue.
Okay.
David,
Thank you, Len.
David, I have
About 20 minutes in the morning when you take it, or half an hour or so. No, then it goes away. So I was on full dose for 2 years, but now I've cut it back to half dose. I'm just watching to see where I go.
Yeah, half dose being 600 milligrams, Peter?
Yeah, a pill in the morning and a pill at night.
Got it. Okay. That's where I'm at, gentlemen. Thank you.
David, I have a question. How
Yes, Gary.
if you have a non-detectable PSA, you're still able to get darolutamide?
I was. I just needed to get off the abiraterone and the Lupron for a while. I was on it for 2 years.
I
Just
thought you
needed
had
a holiday.
I thought you had to be castrate resistant.
No.
No? Okay.
Well,
so
that might have been the approval, but you can get around that somehow. I do it.
So let me address this, okay? First of all, we just saw a trial. I forget the name of it. Arasens. David Musley is going to be our expert in Arasens shortly because he's helping write a patient-friendly paper on a translation of the trial. But Arasens is now using it in a castrate-sensitive, metastatic castrate-sensitive environment. The original approval was for non-metastatic castrate-resistant. Now, as we've talked about many times, that was a Mickey Mouse approval, because if you're castrate-resistant, you're almost certainly not non-metastatic. You're almost certainly metastatic. And a lot of this has to do with the doctor that's applying for you. And if you get a doctor who sticks to the book and doesn't want to go to bat for you, then you can't get it. But we've got people on this call, on this group right now who didn't exactly fit, but they've all managed to get it. So a lot of it depends on who your doc is. And we tend to send people to docs who we think will bend the insurance a little bit for you. What can I say? What can I say? Okay.
Okay.
Can I? We've heard from a couple of people on darolutamide, so I think I'm going to move on, if I may. And I see we have Mark Baldridge and partner present.
Yeah.
So, Mark, what is?
Thank you.
What's on your mind?
My wife, Kathy. I wanted to give just a real brief sketch of my background. I was Gleason 9. I had a prostatectomy. PSA after the prostatectomy, I had 37 radiation treatments. And I've had 13 thus far. I've had 13 Firmagon injections, and my PSA is non-detectable right now. My question has to do with the relationship between hormone therapy and testosterone. My radiation oncologist said that she thought because I'm almost 67, there's a good chance my testosterone will never return. So my question is, if that's the case, I was kind of planning to have 18 months of ADT. My testosterone is less than 10. My question is there still a benefit of ADT even though my testosterone is really low and maybe it never returns?
Well, the first thing I have to say, and as I recall, you see a pretty good radio. Who is it that you see? Is it Heather?
Dr. Dr. Evan Yu.
You've only seen him once though.
You see Dr. Evan Yu. I mean, Yu is a good, he's a good GU med onc, but I don't know where he's getting the fact that your testosterone won't return. You just heard from David Muslin, and he's pretty much, how old are you, Mr. Muslin? 60 what?
67.
67, bingo. So you just heard from a man who's the same age as you, who after being off for how many months has it taken to get back to 250?
4.
Wow. Wow.
How long was he on EGT?
Wow. Yeah, so this was actually a different oncologist, a radiation oncologist who made this statement about testosterone, and what I'm hearing is that this is bad information that I got.
There's another.
I would ask, hold on a second, John, and I'll come to you. I would ask that question to Dr. Yu. I wouldn't be relying on a radon to give you the information. Dr. John, go ahead.
Yeah, I'm sure that's true, Rick. There's another predictor, though, I think that's even more important than age, which is the pre-treatment T level as a predictor of the post-treatment level.
And unfortunately, this radiation oncologist never had him have a testosterone test before he started on hormone treatment. So we don't know what his testosterone level was before starting the Firmagon.
That's not unusual. That's the case with almost everybody. Hardly anybody ever tests testosterone. But
unless they come here first.
Yeah. Yeah.
Are there some benefits of hormone therapy? I mean, is there like a single purpose to drop that testosterone? Is that the sole purpose, or are there other built-in, treatment criteria that take place?
Or benefits.
Okay, so the reason that you go on ADT is largely because the testosterone is known to be the principal food for prostate cancer. And so by taking it out and removing the testosterone from your body, it's one way to stop the cancer feeding. And that's really what we're trying to do. Are there any side benefits as far as the prostate cancer is concerned? I don't think there's any that come to my mind. There may be, I don't think so. I'll throw that one out. But, I think what you're hearing here, Mark, is that we would never say to a guy on this call that we don't expect his testosterone to come back. Some guys it won't, because everybody's different. And even some younger guys it won't. But some guys it comes back in a hurry. So, and some guys, I was 58 when I stopped, or 59 when I stopped, and it took me about 9 months to get back. And then it fluctuated. But the one thing that I think we can say to you, and is that we've said it before, is you should, the recommendation is to be on the therapy for 18 to 36 months and not to get off earlier than 18. And the longer you can bear with it and stick with it, the better you're going to be in the long run, has been our anecdotal experience. But again, we can't give you medical advice. That's just based on people we know.
Yeah. Okay. Thank you very much.
Have you discussed intermittent therapy with Dr. Yu at all? What's his take on that?
Not yet. Well, Dr. Yu, he had recommended 6 months of
of hormone therapy, which I know the group feels like that's not nearly enough, considering I had a lot of adverse effects.
So Peter, that's not his situation. He's sort of getting it as a adjuvant to salvage right now.
Yes.
So
I did too. I did as well. I mean, I went on after my prostatectomy, after my radiation, I went on and off three times.
Yeah, but the first time you went off, it was scheduled. You were Mac said to, and it wasn't Mac who you saw, what's his name,
Albert Chang.
Yeah, you saw Albert Chang, and you and he agreed how long you were going to stay on, and that's how long you stayed on. And then after that your PSA started to climb, so you went back on. But he never said to you you're on. I don't think Albert said to you you're on for the rest of your life when you started with the salvage, did he?
No, I think Dr. Turner kind of ran this one. I don't know if Albert Chang got involved, but I think it was Dr. Turner that I worked with, and we talked about intermittent.
But that's sort of further down the road than where Mark is right now.
Right.
Yeah. Can we just
Anyone else?
Yeah. Mark, how old are you again?
I'm almost 67.
And how long have you been on hormone therapy?
13 months so far, and my insurance just approved up to 24 months. So I was, based on this group, I was kind of planning on 18 months.
Yeah, the group will definitely recommend that. I should know. But your RO told you that you were going to get your testosterone back, and that was a pretty much a certainty or something?
Well, the radiation oncologist indicated that there's a good chance I'll never get my my testosterone back since I've been on hormone therapy for 12 months. She said this was kind of like almost like a magical figure, you know, up to 12 months, better chances. After 12 months, fewer chances.
Well, I was on for 12 months, but I can tell you I was well below the castrate level for about 18, and I still came back to normal levels within about 7 months.
Wow.
And how old are you?
How old am I?
Yes.
Well, I'm 26, but no, I'm kidding.
Yeah.
I'm 66.
Oh, okay. So that's encouraging. Yeah.
I was a tiny bit younger than Mark.
Yeah.
But I didn't have as much hair.
But this is important information hearing from the group that yes, there's a good chance testosterone does return. So
well, I should hasten to add that I met the group after after I met the group, it was recommended to me actually by my RO and then by my MO currently that I should stop at 12 months because they didn't see any point in me continuing. Rick disagreed strongly with that, and I sought a second opinion, and I made the not easy decision to stop anyway. And so far, so good. But of course, I have no way of knowing if it will continue.
Mark, mine came back 3 times after 3 months after I stopped. And I'm 74 now. I was diagnosed in 66. So over the years, it keeps coming back.
Okay.
I think I would ask, I'd go back to your radiation oncologist, Mark and Kathy, and I'd ask her for her evidence.
Yes,
Okay.
I'll do that.
Yeah, she painted a very bleak picture. I mean, it was just kind of discouraging for her to say at 12 months, well, sorry, you know, your testosterone's not coming back.
Well, let me throw in the thing that I always throw in. The more exercise you get, the better your chances of it coming back.
Okay, that's good information too.
Okay.
Thanks.
Thank you.
Both cardiovascular and weightlifting. The more the merrier, it will help you.
Oh, thank you.
Okay, thanks.
You're welcome.
Okay.
So there is.
I just want to mention to Mark that I'm getting my own PSA test and testosterone test monthly. I just buy the test online and go to a LabCorp or Quest, and the testosterone test is $36. A PSA test is $41. So together it's $70. And I just keep closer tabs on it, getting monthly between my quarterly tests.
Well, that's good.
Thanks.
Yeah.
So there actually is some science on this. There's a nomogram for how long it will take you to recover your testosterone.
Oh.
Now, partly it's a function of what your testosterone was, which you don't know, but you
No.
can actually, there is actually science on this. I'll send you the link.
Oh, wonderful.
Thank you.
Yeah, thank you.
That's correct. There's 3 parameters. It'll tell you 3 parameters: your baseline testosterone, your age, and how long you're on ADT. Those are the 3 big ones. But Ben is right. He'll send you the info.
Okay. We gotta keep rolling here. And can we hear from Al Latimer yet? Try again, Al. We can't hear you. Call in, and I think it's got to be something to do with your settings, Al. But use the telephone number and call in. We'll look for a caller coming in right now, and we'll come to you on the caller. Jim Marshall.
Yes, this is Jim. Hey, for a review, I was first diagnosed in July of 2017. I went to straight on to ADT, and I do with Lupron plus the Abbey, and I've been on it now for 56 months so far, and I'm trying to understand the need to take a vacation. Okay, and also another thing, anyway, I have a defective ATM gene. Okay, anybody can explain it to me.
What's an APMG?
ATM gene.
ATMG. Oh, the mutation.
It's ATM.
Right. Alpha Tango Mike.
Right.
Okay.
ATM is a DNA repair protein. So when you have a mutation in ATM, it means part of your DNA repair machinery isn't functioning. And lots of mutations in DNA repair genes are associated with cancer. Some of them are targetable. So for example, Pembro, right? I mean, there are these drugs which are targeting DNA repair are supposed to work in that context. But in fact, the only real successes they've had, or we've seen in the literature, are with BRCA1 and 2. Not so many of the other DNA repair genes.
So what is your question, Captain?
Okay, the question is, should I take a vacation or just continue on until it doesn't function anymore?
And you've been on now for 56 months, right?
Yes, sir.
Okay, throw that one out to the group. Who wants to talk about that? Anybody, or do I have to pick on somebody?
I'll take a shot at it, Rick. This is Len.
Thanks, Len.
And the concern for being on the second line anti-androgens for too long is that you put selective pressure on the cancer to, number one, either work around the fact that you're blocking testosterone so that it'll produce the cells will produce their own testosterone, or secondly, there's a theory that you have a certain number of cancer cells that are right off the bat sensitive to abiraterone, and then you'll have some that are right off the bat resistant. So if you're killing off all of the cells that are sensitive to abiraterone, at some point you're left with nothing but the ones that are resistant. And then you have a more aggressive, difficult to treat cancer. So that's the argument for taking a break, a drug holiday from abiraterone or enzalutamide or any of the others. Plus, of course, when you take a break, you can build up your muscle mass, increase your hemoglobin, hematocrit, bone strength, and also improve your cognition. So that's the logic.
With those, I really haven't had a problem.
Have you had a bone density scan?
No, I haven't yet, but the last one I did have about 2 years ago, it was okay.
Okay, well, that's good. And I guess you're working out, so you're maintaining muscle mass?
Yes.
And what's your hemoglobin? Do you know it?
It is slightly low, so I just got through doing the iron test, okay, the B12, the folate, okay, and the creatine. And so I am now supposed to start up B12.
Well, in the end, it comes down to you and what
Okay.
what you choose to do. But that's the case for taking a drug holiday, what I laid out before.
Okay, provided I take a drug holiday, okay, and the PSA start to rise, I was thinking that I should probably go straight to chemo. Okay, how does that sound?
Jim, I
At that
think
time, you'll still be hormone sensitive. So
right.
I don't see why you wouldn't just go back to your hormone treatment. Simple.
Okay.
Yeah, chemotherapy seems to work better with higher volume disease. So if you have an undetectable PSA, you take a drug holiday, it starts to rise a little bit. You're still very low volume of cancer. So chemo might be a bit of an overkill. But of course, chemo attacks cells that are rapidly proliferating. So if your PSA is slowly rising after the drug holiday, those cells are not very active and they're not going to be very susceptible to chemo.
Okay.
So,
okay, anybody else?
I don't know if that's answered your question, Jim. I mean, I think so much of this is really your own quality of life and risk reward. I mean, we do tend to suggest, of that 56 months, how many of those months has been with abiraterone?
Okay, all of them.
All of them. So I think that we like to see people come off of the come off of the hormone therapy for a while, because sometimes the disease isn't treatable. And so, we've seen people come off, and I think if I were you, I would probably come off. But it's really up to you. I want to try and Carl, if you're still there, we can come to you now. Do you want to come in before we go or not?
Carl is left. I'm the only one left. Okay, I'm really feeling the side effects of the chemo. It's hard for me to be here the entire 2 hours. I'm feeling nausea, a great deal of fatigue, and a burning sore throat. I did notice with Brian talking about his multiple treatments of Geftana and carboplatin. I did send Brian a chat message, but I hadn't gotten a response. So, but I'm just looking for some thoughts as far as if these are typical. I believe these are typical side effects. I didn't expect it to happen after just the third round. I thought it would happen going further into additional treatments. And so I have been given anti-nausea medications, which I am taking. I did unfortunately throw up at least once, which is not a very good thing. So, and I know, Peter, you've had similar treatment with this combo chemo treatment.
Yeah, my experience was it goes, you can tolerate, after about 3 or 4 days, it kind of dissipates somewhat and you're okay. But it's a wild ride, you know, for the first several, not the first day after the chemo, because you're on the dexamethasone, but the day after that, for about 3 or 4 days, it's rough. I agree. It hit me on the third time. Third, fourth, fifth, sixth, yeah, it was rough.
I mean, my treatment was last Wednesday, and now we're here Monday, so it has been a couple of days.
Carl,
Start dissipating.
Carl, this is Brian, and when I first started the first couple of cycles, I had some sores, but I used the magic mouthwash that they give you, and I was pretty religious about trying to keep my teeth brushed and all that with sensitive type toothpaste. But so that kind of dissipated. But what has happened about the 5th or 6th cycle, the fatigue started to come in at a more rapid rate. I go up a flight of stairs and I've got to pause, and my heart rate will jump up, but it goes back if I just rest for a little bit. And I think there's a cumulative effect to the cabazitaxel and carboplatin that, and it was in my 7th cycle that my platelets got so low that I couldn't have the normal 3-week cycle. I had to wait for a 4th. So I think the full effect that happens. And at least that's my experience.
My oncologist has said that maybe the next treatment he might lower the dose somewhat. So we'll see how that goes.
Right, and that's what my guy also talked about, and I think John, who had been on for 23 months of doxytaxel, said he went from a 3-week cycle to a 4-week cycle, and that helped him. So I think there's some things they can do to play around with that.
Right, and my PSA has gone at the beginning of the treatment from 62 to 6, so it's down 90%.
Great, very good.
Good.
Well, we're delighted to hear that it's gone down to 6. Secondly, we know you've got this under your belt, so you're going to be eligible for the Pluvicto, which is another good thing. And I think that, as you're hearing from some of the guys, there are ways to play around with it in terms of the dosage, in terms of how frequently you get it. But I would have to say that this is not unusual. I mean, most of the guys, chemo is rough. Chemo is a rough ride. It's rough on everybody. I think if you ask anybody on this call who's done chemo, and there's a whole bunch of guys here, they're all going to say to you, yeah, it was hard. One thing you may want to try, if you're not, is medical marijuana, because that can often really help with the nausea. I don't know the situation in New Jersey. I know it's available in New York, but don't be shy to ask your doc for for a card and try using it. You know, either with an ingestible or an inhaler. But there are a lot of guys that get a lot of relief from certainly from the nausea.
Yeah, I do have that card, and in New Jersey, they have dispensaries, which are the official locations that you go to only with the admittance of this card issued by the doctor. And if for whatever reason in New Jersey, they do not allow edible medical marijuana, and the only thing that they do have is a like a mint that can be taken. And I have tried the tinctures, but I've had mixed results.
How about going over into New York to get edibles, or to Connecticut?
I don't know if that, oh, you're saying without the need of a card, you can go to those states?
No, you can just use your card over there. I don't even know whether you need a card in New York or Connecticut. I don't know, but if you've got the card, you'll be able to go to either place.
I think the cards are state specific, Rick.
I think I think you can use a card in any state. If you're in another state, I thought you could use it, but maybe I'm wrong.
No, I couldn't do that in Florida. I had a Connecticut card. I couldn't use it in Florida.
Okay, there you go. All right, I'm wrong. I am wrong.
I just want to say, Carl, my old pharma company that I worked for produced a drug called Marinol that was, you know, an oral medication that contained, it was for nausea, cancer-related nausea. So you might want to ask your doc about that. Marinol.
Okay. He gave me two different medication, ondansetron, and something starting with a P.
New York has legalized the marijuana. You do not need a card. You can buy anything you want. They've and edibles are much better than smoking.
Hey, Carl, you know, when I get my cycles, the chemo, I probably get a half dozen to up to 10 different other drugs that are meant to help mitigate the effects. If you send me your email and I'll send you the drugs that I'm taking along with the dosages of the chemo when I get it.
Okay, thanks.
I mean, there's all kinds of things that are supposed to try to prevent having those kinds of difficulties you're describing.
All right, appreciate
that.
Yeah.
I mean, the anti-nausea drug that you're talking about, Len, what's the trade name for that? What's the commercial name for that?
The ondansetron.
Yeah.
Yeah, you know, I'd have to look it up. I can't recall the trade name.
I'm just spacing it out, but I think that's one that we know people have had fair success with. I can't look it up right now. Are you using a mouthwash?
Oh, it's Zofran, Z-O-F.
Zofran, right. That's it, Zofran, right.
Yeah, so I am using mouthwash.
Okay. So again, you know, this is another reason why we like for you to have palliative care docs online, because they're really good in figuring out ways around this stuff. You know, this is what their business is about, the palliative care docs. They're not end-of-life docs. So when we say get a palliative care doc on your team ahead of time, this is exactly the reason why.
And I do have one, yeah.
Okay, then have you talked to them about these side effects?
No, actually, it's been only within the past couple of days that it's really hit me hard. So I will send them an email.
Yeah, I would set up a consult with that palliative care doc as soon as you can, because they're going to have tricks up their sleeve, and then you'll share them with us and we can share them with other people.
Okay, thank you.
Definitely. All right, I'm gonna keep rolling. I'm gonna go through to cover everybody, but please drop off if you feel that you have to. Jim Marshall, I'm sorry I had to jump away, but we were about to lose Carl.
No problem.
I think, Jim, that you got to talk to your med onc and make the decision as whether you want to take the plunge or not. And we've got other guys who have done it here, so.
Yeah. Okay. I thank you very much.
Okay. Okay, Al Latimer, can we hear you now?
Can you hear me now?
Yes.
No.
Yes.
Yes.
Yes. Yes.
Okay, so I rebooted my machine and apparently all is well. Don't know what that was.
Okay, go. You had something for us.
Well, like you mentioned before, I've had all 6 of the lutetium treatments now. And I've had a follow-up PSMA scan a couple of weeks ago, and essentially where I was lit up like a Christmas tree before, it was almost nothing now. And my PSA went from 60 to 1.5. So Dr. Scholes wants me to keep the pedal to the metal and add Abby to my, well, right now I'm only on ADT, add abiraterone to that and see if we can drive the PSA even lower. I'm kind of inclined to wait and see. I have another PSA test this week. I'm kind of inclined to wait and see whether or not my PSA is going to go down any further, because the doctor at UCLA said that it's possible that there can be some residual effects for a couple months after the last treatment, which is where I am now. I'm about 2 months after the last treatment. So we'll see what the next PSA shows and go from there. He's also talking about, if that doesn't work, to try Provenge. So that's kind of where I stand.
Well,
but that's, Al, that's good news.
A couple of things first. First of all, the one thing that you might want to discuss is a monotherapy at this point, like some of our other guys have done, where they've just gone on to either Abby or darolutamide or apalutamide monotherapy, so that you're not suppressing your testosterone. I don't know how Schultz would feel about that. Secondly, the earlier you get the Provenge, the better you are. And there's no harm to do Provenge, as I think is what Herb might have been wanting to say, and I'm going to go to him momentarily. Go ahead, Herb.
No, I think, well, first of all, it's the drop in PSA and the scans are obviously very good news. It certainly makes me feel good, even though I don't have any results. But I think, again, if things continue and you need more, Provenge would be the right thing to do.
So my understanding is that you have to have a couple of consecutive increases in your PSA before you become eligible for it.
Well,
is that correct?
But
yeah, but you had that before.
You're castrate resistant, Al. If you're castrate resistant, that's enough.
That's enough. Okay. Well, I was about to do Provenge a year ago when the lutetium came along, and I've been on that route really for the last 12 months.
So Al, how many? You had 6 cycles?
Yes.
At 6 weeks each?
Yes.
So yeah, so that's sort of what what it's all about. And what about side effects?
Well, I've had fatigue, like you were saying. That seems to have abated somewhat. I am suffering from the dry mouth still. I think it might even be a little worse now. Certain foods taste a lot different. Certain things I just don't eat at all now because they just don't agree. They just, they make the dry mouth worse. like spaghetti sauce. I love spaghetti sauce. I can't eat it. But I use biotin and biotin lozenges, and that really helps a lot. So,
Well, you know, I think that you have a history of being castrate resistant before you did the lutetium. So I'm pretty sure that you should be able to get the Provenge either through Schultz or through, you know, whoever you're seeing locally.
well, I was already approved for it. I contacted the prostate doctor at University of Miami, and it was all set up, and I was ready to go when the lutetium came along. So I can, you know, I'm planning on reactivating that. But Schultz wants me to try another round of Abby first, so I'm fine with that. I mean, my PSA is only 1.5. I'm not going to let it go. I'm not going to let it go at all. I mean, I see it start rising. I'm going to be going after it. That's for sure. The UCLA doctor says I could get as much as a year before my PSA starts rising again. So I don't know. We'll see, I guess.
Who are you seeing locally?
I'm not really, well, I had a doctor at University of Miami that, well, trying to find some place around here that did Provenge wasn't that easy, but I found that University of Miami does it, and that's where I went. And I don't even remember the doctor's name there at the moment. If you have another recommendation or idea.
No, what I was going to say to you is we have a meeting next week with Belusic. We haven't really used him, but I think he's on the ball. He's certainly a good GU medonc. And then the other guy that's there is the Indian guy whose name escapes me just for the second, but he's out of town a lot. He's only there about half the year.
Something like Singal or Singal? Or...
Yeah, that's it. Singal, I think that's right.
You're talking about at the University of Miami?
Yes, at the University of Miami.
Let me see what the name is. I haven't seen that doctor in a year. I forget his name. Maybe that sounds familiar though.
Singal?
You see.
So, but just the other name, and we'll know him better. Herb and I are going to meet with him in a couple of weeks.
I'm looking to see if
is Belusic. So, I got to keep moving, Al. Sorry.
Yes, the doctor. The doctor I met at University of Miami was Singal.
Okay. Well, Belusic is another alternative. And I also sent you David Muslin's telephone number. Call him. I know he'd like to get together with you. He's just up the street in Boca.
Okay. I was planning on doing that. I just been busy.
Okay.
But I will do that.
Okay. Let me see. Where are we here? Who's left? Is Joel? You're left. Let's go to you next.
Yes, thank you, Rick. I attended the PCRI conference 2 weekends ago, and Dr. Vogelzan was one of the speakers, and he said that because PSA is a good marker but not perfect, he recommends to metastatic patients to monitor their alkaline phosphatase, the LDH, the D-dimer, and the fibrinogen. And I went to my PCF doc today and asked for those, and she queried me a little bit and gave them to me, and so I have an order to go to Quest on the 8th of March to get those done. I already heard tonight that somebody was doing an LDH. are any of the people on this call doing those 4 different tests in addition to the PSA?
Absolutely.
There's a lot of
Day,
people
from
that
day
do.
one.
There's a lot of people that follow their bone. Which of the bone ones?
Alkaline phosphatase is one.
ALK, yeah, ALK and ALP. A lot of
Right.
people. Most of the guys follow that. What were the other two, Carl?
D-dimer and fibrinogen.
Those I'm not so sure of.
The fibrinogen is a blood clotting factor
Right.
score.
Yes. Yes.
And he said that they need, all these indices need to be moving in a positive direction, whether they're going up or down, but you need to know where they are.
Len, do you want to comment on those tests?
Yeah, the D-dimer in this case is being used as a measure of inflammation. So of course, inflammation is not good in cancer. I mean, it's also used to determine whether somebody's had a heart attack, but that doesn't really apply to the case of prostate cancer. In prostate cancer, they use it as a measure of inflammation. And, just recently listening to Eugene Kwan, he was being interviewed by Mark Moyad, talking about the LDH and the ALK-Phos. And, nothing is a silver bullet. He said he has seen patients whose skeletons light up and their ALK-Phos is normal, their LDH is normal. So, I mean, I'm not arguing against, monitoring those parameters. You absolutely should. But just like with PSA, it's not a silver bullet in either of those. So it's good to monitor all of them.
Okay, very good. One quick question. Since my treatment, my second treatment of SBRT, I was planning to take another PSMA PET scan to see if the radiation oncologist got it all off my neck. But the question came up in the conference again when Dr. Kwan was speaking to Dr. Moyad. And he says, well, you can have different types of prostate cancer. You can have non-PSMA expressing prostate cancer, and you can have PSMA expressing prostate cancer. Should I then not, if that's the case, after I take a PSMA PET to ensure that the radiation oncologist got it all off my neck, shouldn't I take an Axeman PET scan to see if I have other prostate cancer in me?
Why don't you talk about this concordance issue?
Well, there was a therapy trial in Australia. It was done ahead of the Vision trial for lutetium. And the way they conducted the trial in Australia is every patient was screened not just with PSMA PET, but also with FDG PET. And the patient had to be positive for PSMA and negative for FDG. So that's one way to approach it. I guess you could do Axeman also, since Axeman is not based on PSMA, it's based on synthetic amino acid. And so it's a measure of metabolic activity of cancer cells.
When I went to NIH, the clinical trial for my first PSMA, they gave me an FDG. And FDG was positive also. So I have a positive FDG and a positive PSMA.
Well, Joel, it would be hard. I mean, given if a cancer will show positive FDG, so that just shows that there's something there. It doesn't show that it's prostate, and it doesn't show that it's PSMA positive. So the concordance is what they're looking for. They're looking for the fact that the cells are both PSMA avid and FDG positive. The bad sign is if you're FDG positive and then PSMA negative, that would mean that you do have cancer that's not expressing PSMA.
Right. So let me, couple of things here. The first is that I'm not sure that Len expressed it in what he meant, but what he was trying to say is that, I think, is that in that trial, they were just trying to make sure that all the cancer that they saw on the FDG scan also expressed PSMA. That was what they were looking to do.
Yes.
And so, and now, we just had a situation this week with one of our participants, they're not online, and they did a PSMA scan, and they were gearing up to thinking about getting ready to do Pluvicto, and he had a medical crisis. Part of that, they did an FDG scan, and they found cancer in his liver, and they biopsied it, and it turned out to be prostate cancer, and that prostate cancer never showed up on the PSMA scan. So that's a really good example of where the FDG and the PSMA were not concordant. And so for this man to be doing Pluvicto may not be the best idea because we're not going to get all the cancer with it. But, you know, in your situation, where you've done a PSMA scan, where your neck did light up with the PSMA, you know, I would say, are you sort of overthinking it if you think that there would be other cells right there that did not express PSMA? I don't know enough, but from what I understand, you know, if the cancer shows up, it's likely to be all that cancer in that area. I mean, it's not likely to be, you're not likely to have both types of cancer in one place, but that's just my understanding. And I think you'd have to ask that question.
Yeah, I'm not so concerned about two cancers being in one place. I'm more concerned about another spot of cancer or someplace else in my body. So I guess my question is, how do I know if I have only one type of cancer or not?
Well, it's not that, okay. You do a PSMA and you do an FDG scan right around the same time. That's the standard way of doing it. You do the FDG scan, you see if that shows any cancer, then you do a PSMA scan. Now, of course, you've got to have a high enough level of cancer to show anything up. What's your PSA right now?
3.7, taking another PSA in a couple of days. Hopefully it'll be down because of the treatment effects from the SBRT.
So, you know, it might not be a bad idea if you can get it to get both and at the same time and see if you're concordant. I don't know. What does the Brains Trust think?
Yeah, that's the whole point of using FDG, to see if they kind of overlay the two images, Joel. And if they see lesions that are only FDG positive and not PSMA positive, then they would exclude you from treatment with lutetium, at least in Australia. I don't know if they would do that here, but that's the way they screen patients in Australia. So it's not a different type of cancer, it's prostate cancer, but some prostate cancer cells produce PSMA and others may not.
Yeah, the reason I'm concerned is my PSA has always been very low. I've never had a PSA of higher than 3.8. And so I'm wondering if I may not have cancer that doesn't express PSA in addition to what I have.
Well, the FDG scan would tell that, Joel.
Okay. Very good.
Have you done chemotherapy, Joel? You haven't, have you?
No. Never gone that far.
In order to get the lutetium right now, you'd have to do chemotherapy first anyway.
Yeah.
You'd have to do a taxane chemotherapy.
Right, understand. And there's 3 trials right now that are doing lutetium-177 without chemo, but they're in clinical trials right now.
Right.
Well, you've got to be sure they're still there. If those trials are, if those were the managed access trials, none of them are in place anymore. But there are other trials. So, for example, Tagawa's doing it with a different ligand, and there is a trial going on for castrate sensitive. I forget the name of it right now. But there are other trials. But if it's a trial that was part of the Pluvicto approval, it's no longer running.
Okay. All right. Thank you. You've answered my question.
All right, guys. Is there anybody still on that? Gary Peters, you had something you wanted, and I had you ticked.
I had just started going to the gym in late February, and 3 weeks ago I was doing a back exercise that I had done many times before with a light weight, and it turns out I fractured a lumbar vertebrae.
Oy.
So my hope is that this is going to heal naturally. It's going to take a while, but I don't know how that works with weak bones. I had already had osteopenia in my lumbar spine, so I was just wondering if anybody had any thoughts or any experience with this.
Are you on bone strengtheners, Gary?
They gave me my first shot of Prolia a few days ago. I'm not sure I want to stay on Prolia, but I got my first shot Thursday.
Yeah. So, I mean, the only knowledge I have of anything similar is that my sister recently fractured her hip, probably from, it was almost a stress fracture. She almost stumbled, but she didn't. And they found a fracture in her hip, and they've told her she's just got to hang in. Now, she's been on Prolia and Fosamax forever and a day for osteoporosis. You know, I was thinking you might have been on one of these drugs for a long time, because that's the sort of thing that can happen when you've been on the drugs for a long time. But that's the only knowledge I have. Anybody else want to contribute anything to Gary about how to heal this sort of this hairline fracture in his vertebrae?
Yeah, it wasn't hairline. It collapsed.
Oh, really?
But are they, did you, is there, the x-ray showed it's clearly separated and out of position?
It collapsed on itself. Just caved in.
Okay, so here's the concern. Here's the big concern that I would have, and I don't want to scare you, but I think that you should be talking to your GU med-onc, is whether you had prostate cancer in your spine. Because that's the sort of thing that would happen if you had prostate cancer in your spine, if it collapses like that. I mean, have you ever been diagnosed with prostate cancer in your spine, Gary?
No.
When was the last time have you ever gotten a PSMA scan?
No, my PSA was not high enough.
And it still isn't, right?
Right.
Well,
I'm due for another bone scan.
Well, that would be better than nothing.
I mean, it does sound to me, are you seeing Ching or whatever her name is, or the
No,
lady in
Carducci.
Fairfax?
I have seen her. My regular person is Carducci.
All right. Okay. Well, have you reviewed this collapse with Carducci?
I've told him, and he's aware of it.
Well, you know,
He
I'd
didn't.
be pushing Carducci or Aragon Ching because you're concerned that this could be a result of prostate cancer.
And
See
what
what they say.
what should I ask them to do? What would I ask for?
That's why they pay them the big bucks and not me. You know, I mean, I would say that if your PSA was higher, you could get a scan. You know, it may be worthwhile letting your PSA run up so you can get a scan. Some people will do that, but you've got to talk that out with the good GU med onc. But I think that for your vertebrae to collapse just on the basis of using some light weights, it sounds awful suspicious to me. And if I was a GU med onc, I'd be working with you to see if I could figure out what the heck was going on. I mean, that's my view. Anybody else want to comment on that?
Yeah, that's how I was diagnosed, Gary, was I had a T12 compression fracture, and that's what led to the diagnosis. And that was from most likely, it's difficult to say, but I think it probably happened when I was trying to figure out why my back hurt so much, and I was going to my physical therapist and trying a bunch of different things. But the big concern for me was that I got attached to these spinal neurosurgeons who kind of didn't want to let me go, and they really scared the hell out of me. But it turns out, you know, I was pretty stable. They were really worried about some kind of spinal column, you know, compression. So yeah, I mean, I had an MRI, then I had a bone scan, and everything became clear, you know, what was going on. But I would think that if you're going to have a bone scan, that'll tell you what's going on. And I don't know, maybe you should have an MRI too, which is part of my diagnosis.
Would an MRI show cancer in the spine?
They did it in my particular case because they were trying to isolate, you know, what was going on. They didn't really even know where the tumor was at that particular point. So I don't know, maybe somebody else can tell you about that.
Herb, would an MRI?
Well, I think
reveal...
I think it'll show something if it's there. I mean, again, I think, but I would argue that maybe a technetium bone scan would also show something if it's there. But Gary, I would definitely ask Carducci to order a bone scan ASAP.
Okay.
Well, Herb, I wouldn't ask. I would say to him, what scans can we do? Right. Because it might be more than could be more than a bone scan. Maybe he needs a technique. Maybe he's too low for an Axumin scan as well.
Right. Right. I mean, obviously the level of PSA is low, but it may be that an FDG scan will show something.
Yeah. You know, a bone scan,
Gary,
an FDG scan.
I think the answer is go to your My Chart, write Carducci a letter saying, I'm very concerned about this vertebral issue. What can we do for better diagnosis to make sure it's not cancer?
Right. To make sure the vertebrae did not collapse as a result of prostate cancer.
Right.
Exactly.
An FDG scan and DEXA.
No.
Just say, what can we do to make sure that this vertebral issue is not due to the presence of prostate cancer.
Okay, thank you.
All right.
Put
In
him
other
to
words,
rest.
Gary, we usually want to tell the guys what we want, but we don't know here because you're so low. So put it on Carducci's plate because he should know what to do to try and check out what's going on. Because if God forbid there's cancer there could be cancer somewhere else in the spine. We've got to look and see what we can do right now to strengthen the spine because we don't want you in a worse situation. It's one of the first places the cancer goes. And a lot of times we have great concern when we put men on agonists, as we were talking about before, that the agonist can cause a spinal collapse. That's why they give you the bicalutamide first. So the first thing that, I mean, I thought it was a fracture. I didn't realize that it was a whole collapse of a vertebrae. If it's a collapsed vertebrae, that waves red flags for me. Does Carducci have pictures of the collapsed vertebrae?
Yes, it was uploaded to my record there, and I'd actually seen him on Thursday, and you know he didn't suggest any other scan at the time. I didn't ask him in this pointed way. I can do that.
I think you have to, and if you don't get a response, I'd go back to Aragon Ching and see what she says.
So Gary, where were you treated for the spine issue?
I haven't been. I'm going to see a spine surgeon tomorrow.
Where?
Michael Goldsmith. He's at Summit Orthopedics. So they're not treating it at this point other than to give me a brace and say, you need at least 6 weeks of being very quiet and then 6 weeks of physical therapy. And
then the other point is if you're going to see a spine surgeon, I would ask him the same question as you might ask Carducci. Are we sure that this isn't due? Is there a way we can rule out that this isn't due to my prostate cancer? Because they should have insight into it as well.
And
Absolutely, I agree with her.
What about asking a radiologist?
Do you have an X-ray, Gary?
I have an MRI that was taken that showed the collapse.
Yeah, when I went to the specialist, he wanted an X-ray too because he wanted to look at the integrity of the bone.
They did take an X-ray last week. I saw his nurse. So they have an X-ray.
Oh, then they probably got your other bones around there too. So that'll help when you see the spinal neurosurgeon.
Right. The point Cal just made is really important, that this is all about the integrity of the bone, because what happens with prostate cancer and the reason the bones collapse is because the prostate cancer kind of makes the bone like marshmallow. And so it just gets soft and it's very difficult to work with. And so we've got to verify that the integrity of your bone is still good. And if the integrity of the bone is still good, it's probably, again, I'm not a doc, but this is just my understanding. If the integrity of the bone is good, then it may not be prostate cancer. But if the integrity of the bone is not good, it could be a result of the prostate cancer. I don't know how they do that, but I think they can do it. So you've got to push Carducci and you've got to push the spinal surgeon tomorrow and anybody else you want. Could you ask a radiologist? Are we talking about a radiation oncologist or a radiologist?
the same radiologist who treated Joel, I saw him and I liked him.
He's a radiation
But he's a
oncologist.
radiation oncologist.
Right.
So that's my, so, yeah, I mean, you know, you could ask him too, if he's a radiation oncologist, but the guy who treated Joel was I thought he was a special head and neck guy.
No, he was a radiation oncologist strictly, does all types of radiation.
Okay.
Recommended by AnCan Herb, by the way.
Okay, well, go for it. But
Yeah,
let's
Gary,
try and rule.
Gary,
Go
what you
ahead.
want to know is how good all your other bones are around the bone that collapsed, you know, and
Exactly.
that's like really, really important to know how strong all your other bones are.
Exactly.
And your physical therapist is going to want to know that too.
Okay. Thank you.
Really, it's just we've really got to verify the integrity of these bones, and go from there.
Yeah, I have a quick comment about Prolia. He said he didn't like it, but I'm never taken Prolia, but I have a friend who's 115 pounds, female, and she's been on Prolia for years. Before that, she took many other bone strengtheners, and it never worked. But Prolia has actually built up her bones, where she has the hips of a 19-year-old now. The doctor claims. So the Prolia does work.
Yeah,
It certainly increased my bone density.
Right.
You're taking it, Herb?
Huh? Yes.
You're still?
Yes. I'm not going to go off it. Why?
So here's the issue with these bone density drugs. They do work, and they do make your bone density stronger. It happened to me. They put me on Zometa, and it worked for me. They also make your bones more brittle.
Right.
In other words, they become denser, but they become less flexible.
Right.
And so you're more susceptible to a fracture in the bones from a sudden shock.
Right.
So there are pros and there are cons. Yes, the bones are thicker and they're denser, but they also are more likely to fracture. It's like a, what's the word I want? Where a contradiction in terms. What's the word for a contradiction
Paradox?
in terms? Paradox. Thank you. Thank you, my wordsmith, Mr. Nathanson. It's paradoxical.
Well, Gary has a paradox to look at it.
Yes. Gary,
Okay.
I'm so pleased we got to talk to you about this. This is so important. You got to chase them down, including Carducci, and say you want to rule out prostate cancer for the vertebral collapse.
Okay.
Keep us posted, man.
Thank you.
Herb's around.
Right. Let
He's
me know
local.
what's going
You
on.
can call him, call Herb, call me. But let's get him. Herb is.
Right.
If you're having any issues with Dr. Carducci, call Herb for some guidance.
Right.
We've found out some things. Carducci is a very, very warm, amicable man, as long as there's no computer near him.
Well, I think Herb is on a first name basis with him.
Right.
So,
Well, while I was having, I mean, it's late, and anybody want to sign off, they can sign off. While I was having my infusion of lutetium, the oncology nurse was there, or the nurse was there, and she.
Herb, I'm going to stop the recording, okay? And
Okay.
then we'll stop the recording right now, okay?
Right.